Okay, I'm delighted to introduce our second speaker for this panel. Crystal Brown is a clinical instructor at the University of Washington School of Medicine in the Division of Pulmonary and Critical Care. Thank you, Crystal.
Thank you. Can everyone hear me? Okay.
Yeah.
All right. First of all, thanks a lot for inviting me to the symposium. This is very exciting. And I'm going to talk a little bit about disparities in healthcare intensity at the end of life with a focus on the intensive care unit. And I have way too many slides, so I apologize in advance. I just got really excited. So first, I'm going to talk about what we know about disparities in healthcare utilization at the end of life, and then I'll talk a little bit about a study we've done here at the University of Washington and Harvard B Medical Center looking at race and healthcare utilization in our ICUs here, and offer some potential explanations as to why these disparities exist, and then try to summarize these findings. So I'm going to start out on a little bit of a personal note, and before I get started, when I ran these slides by my husband, he was like, this is very antagonistic, so I'm going to try to... So I'm going to compare two different types of deaths. So if any of you are from Houston, this is Sunnyside neighborhood. It's where my dad grew up. It's the hood. It's been called one of the most dangerous neighborhoods in the country. And this street, is this a pointer? Oh, it doesn't matter. Oh, well, okay, the street here is Brandon Street, which is where my dad grew up, and where my grandmother lived. And my grandmother was, and this neighborhood really still suffers from the after effects of segregation. My grandmother was schizophrenic. She had dementia. She had a really prolonged dying course. She had a feeding tube. She had multiple hospitalizations, and eventually she died in the hospital. Contrast this to my husband's grandfather's neighborhood. He lives in this place called Windermere by Children's. I'm not mad at you if you live in Windermere, but his house is worth $2.5 million. He has a lot of money. He has access to home health services, palliative care. He's nearing the end of his life, so if he needs it, he'll have hospice at home. He's like, I don't want to go to the hospital, and he is able to have resources to do that. And so my husband's grandfather and my grandmother will have two very different deaths. And so this is sort of a segue into what I'm going to talk about next. And so what do we know about disparities in healthcare intensity at the end of life? So I'll just go over some studies that provide some background information. So we know that there is a difference based upon race, that your death will be different. So for example, in one study looking at Medicare data, looking at inpatient intensity, healthcare intensity in the last year of life, we see that if you survived your hospitalization, you had lower utilization of ICU services and intensive procedure use. So this is consistent with the general trend that minorities usually get less intensive medical interventions throughout their life. They have access to and receive less preventative services and less diagnostic testing, less preference to supply sensitive procedures. So these are things like cardiac catheterization and orthopedic procedures. However, at terminal hospitalizations, their last hospitalization in which they died, Black decedents actually had higher utilization and were more likely to die in the hospital compared to their white counterparts. And this included higher things like a breathing tube, so being intubated, receiving a tracheostomy, getting mechanically ventilated, receiving feeding tube placement. Black patients were more likely to receive these things than their white counterparts. Again, this is looking also at disparities in hospice enrollment. So, as you know, hospice is for patients who are expected to live 6 months or less. And so this is an analysis of newly diagnosed cancer patients in a Medicare database. And really what they were looking at was, in the study, was hospice enrollment and lengths of stay, and whether or not someone was enrolled within 3 days of death. And if you think about it, being enrolled 3 days before you die is really a marker of underutilization. And again here, and these results persisted after adjustments for socioeconomic factors. Whites were more likely to be in hospice than Hispanics, who were more likely to be in hospice than African American patients. And again, in the study, Black patients had more hospitalizations, longer lengths of stay, and were more likely to die in the hospital. A few years ago, there was a study looking at socioeconomic disparities in the ICUs here in Seattle. So this was a secondary analysis looking of an intervention looking to improve palliative care in 12 Seattle area ICUs. And non-white patients were more likely to be younger, to have lower levels of income and educational attainment, and were more likely to be uninsured. They were less likely to participate in advanced care planning, so things like living wills or having a power of attorney designated. They were less likely to withdraw life-sustaining treatment or to have a do not resuscitate order, and more likely, again, to have high-intensity healthcare interventions at the end of life, such as dialysis, mechanical ventilation, and compressors. And again, this didn't really alter in various, in looking at, depending on what hospital you were looking at. So here now I'll talk a little bit about what healthcare intensity is like in the last 30 days of life here at UW Medical Center and at Harborview. And so what we did was, using Washington State death certificate data, we identified patients who died between 2010 and 2015, in patients who were attributed to UW Medicine. And this criteria is similar to that used in the Dartmouth Atlas studies. So patients had to have 1 or more inpatient stays in 2 years prior to death, or 2 or more outpatient visits from the same facility in the last 32 months of life, with 1 or more visit in the last 24 months of life at either UW or Harborview. So these are inpatient outcomes at UW or Harborview here. And the analysis here was done with binomial regression models and also some path analyses that I'll talk about. And here are our confounders. Am I going too fast? Okay, all right. So we identified about 22,000 people for our study, most of which were male, about equally split between married and single or divorced. No surprise here, but predominantly white, 82%. Our next highest represented group were Asian Pacific Islanders, and then 6% Black. Some other information on our demographics here. Income, 45% of people only had a high school education or didn't finish high school, which I thought was always surprising to me. And again, about a third had private healthcare insurance, another third had Medicare, and then the rest Medicaid, military, or uninsured. These diagnoses these 9 diagnoses can be attributed to, so 9 out of 10 Medicare deaths in the patient population are associated with 9 chronic illnesses. And again, this is from work done at Dartmouth. And we see here that most of our patients, a little over half, had cancer, next followed by COPD and coronary artery disease. 41% of our patients here died in the hospital. 3% received CPR, and 13% received mechanical ventilation. And so what we see here, I don't think I actually clarified what our 3 outcomes were, so I apologize for that. So our 3 outcomes were whether or not someone was admitted to the intensive care unit at the end of life, whether or not someone received mechanical ventilation, and whether someone received CPR, so the likelihood of those things. And so what we see here is, again, differences in your likelihood of being admitted to the ICU by race or ethnicity. So Black, Asian, Hispanic, and mixed kids like me are more likely to be admitted to the ICU compared to white patients. And white patients serve as our reference sample in the next 3 graphs. Again, we see disparities or differences in mechanical ventilation by race or ethnicity, with almost all racial and ethnic groups more likely to receive mechanical ventilation compared to white patients. And lastly, African Americans and mixed patients being more likely to receive CPR compared to almost all other groups. So why is this? So one of the things that we did to try to tease this out a little bit further was to perform path analyses. So path analyses is just an extension of multiple regression, and it's really to try to estimate the magnitude and significance of hypothesized causal relationships between our variables of interest. So we have what's called a direct path from race to our outcomes of interest, and then I just want to light someone's eye up. Nope. Spoiler alert. Okay. I give up. So there's a direct path from race to our outcomes of interest, and then we also have many other indirect paths from race to our outcomes of interest. So for example, we have a path from race to income, to, for example, CPR, or from race to education, income, and insurance. And these paths were hypothesized based off of what we know about socioeconomic status, race, social determinants of health in the literature. So the next slide, so the direct effect is, again, this direct path, and the indirect effect is the sum of all of the indirect pathways. And so what we found is, in looking at ICU admission, there's almost, and mechanical ventilation, there's almost an equal amount of direct and indirect effect between race and ICU admission and mechanical ventilation. And then here with CPR, we see almost a total direct effect of race alone on likelihood of receiving of CPR. And in general, these are pretty small paths. So why might this be? So I'm going to offer some ideas, and of course I'm more than happy to hear feedback. But so we know that there's differences in preferences, and a lot of this work has been done in Black patients more so than other racial or ethnic groups. So Black patients are more likely to want CPR, mechanical ventilation, or other intensive, high-intense healthcare interventions, even when presented in various medical scenarios. So there was one study that said, okay, let's say you're bedbound and you have dementia. Would you still want CPR, dialysis, and all these other things? And Black patients were more likely to say yes, they wanted these things. Black patients are less likely to have a living will or a DPOA or a power of attorney, and then less likely to have had informal discussions with their physicians or family members about their healthcare preferences, and are less likely to discontinue aggressive end-of-life care. And so why might these preferences exist? I think a lot of it has to do with trust. So a long legacy of discrimination and disenfranchisement in the Black community. There's a concern, it's like about a physician's motives. So like, why is this physician talking to me about end of life? Are we trying to, are they trying to get paid? Or are you trying to, protect yourself from getting sued? And there's this concern that having these documents might make one more reliable on a physician rather than having a collaborative conversation about one's healthcare trajectory. There's a value of family, of course, but there's not a lot of confidence that family will have an empowered voice when making decisions for them that can no longer speak for themselves. And there's also this idea that maybe perhaps religion or spirituality plays more of a role in thinking about the end of life as well. Acculturation, so acculturation meaning sort of adapting our own American westernized beliefs. And I'll give you another personal example of this. So my mom is Korean, and when her mom was in Korea and dying, she would be on the phone talking to her siblings, and with ideas about what to do for her mom, and they were like, "You're so American." So again, these are ideas that are more prevalent in these cultures, and I certainly don't want to sound like I'm stereotyping, but for example, positive thinking, or being told, or truth-telling, or believing that you should be told of your terminal illness. So if you talk about, the concern is if you talk about death or plan for death, you will bring upon your death. And there's been some interesting qualitative studies with Japanese physicians and Japanese American physicians. So Japanese physicians being more hesitant to recommend withdrawal of life-sustaining treatments, whereas Japanese American physicians are perhaps more comfortable with that. Knowledge. White adults are more likely to be knowledgeable about advanced care planning, and African Americans are more likely to report not having a living will or advanced care planning, or to have participated in any of these types of discussions due to a lack of knowledge. And then lastly, communication. So you might say, like, okay, Crystal, like some of your references are like sort of old. Haven't we done better? We really haven't. So there was a study that came out last year in JAMA that looked at a cohort of Medicare beneficiaries who lived in the community and looked at 3 advanced care planning outcomes, whether or not patients had an end-of-life discussion, a DPOA, or advanced care planning. And again, these disparities still exist. And this tells us that even an increase in comorbidities did not increase the likelihood of someone having talked about their end of life or planned for their end of life. So we're not doing a really great job in communication. I'm not sure that, I'm not 100% confident that reimbursement is going to necessarily increase these conversations. And I think a lot of it has to do with how skilled we are in talking about end of life. So I think palliative care does it really well. So palliative care is a specialized medical care for people with serious illnesses. And it provides a higher quality of life, decreased intensity of care, lower costs, improves symptom management, and higher quality communication. And there's a study actually done by one of our colleagues here that showed that inpatient palliative care may improve access to palliative care and hospice for patients from racial or ethnic minorities. And that inpatients and that these consults in the inpatient setting may neutralize differences in healthcare intensity at the end of life. What I think was interesting are some of the reasons why people got these consults. So physicians are more likely to say that there's this discord with their Black patients, or they might view conversations with Black patients as more difficult, or they may see Black patients as needing additional resources via hospice or palliative care at home. So I think that's also interesting to talk about. So I'll just finish up by saying maybe in our PATH model, what we need to think about here are these 4 things: trust, acculturation, knowledge, and communication, when thinking about our patients and planning for their end of life. So with that, I'll end there. Thank you.
Thank you so much to Crystal Brown. And now we have 2 speakers who are going to be our last presenters for this panel. What do you want to do?
It's hard to get over there.
Yeah, what do
I
you
can
want to
stand
do?
here or just stay right here.
Whatever you would prefer. So let me just introduce our 2 speakers. Tim Brown is a PhD student and research assistant at the Department of Philosophy. He also works at the Center for Sensory Motor Neural Engineering and the Biorobotics Laboratory. Sarah Byrne is Associate Professor of Philosophy at the Philosophy Department, as well as at the Program on Values in Society, and has affiliations with the Department of Bioethics and Humanities and the Disability Studies Program. She currently leads the ethics thrust at the Center for Sensory Motor Neural Engineering. Really tricky to say that.